Hello people, in this video let us look at blowout fractures of orbit. So where is orbit? This is the orbit, right? So blowout fracture, so somebody punched and there is a fracture here. So that is blowout fracture. Name itself says everything, isn't it? So what are we looking at in this video? Blowout fracture of orbit. So the orbit has frontal bone, zygomatic bone, maxilla, lacrimal bone, ethmoid bone, and then sphenoid bone. So many bones are there, and there is a fracture. So fracture usually we refer to what? Bone, right? So here we are looking at what? Blowout fracture. So it is an isolated, comminuted fracture which occurs while the orbital walls are pressed indirectly. So they are pressed indirectly means what? Comminuted means reduced to minute particles or fragments, and it is an isolated fracture, comminuted. When the orbital walls are pressed indirectly, then how do you press the orbital walls directly? So what they are saying here is mainly what gets affected is the orbital floor and medial wall. See, here we are not talking about injury to the globe. We are not talking about the eyeball. We are talking about the structure that contains the eyeball, that is the orbit, okay? So and what is affected most? Orbital floor and then the medial wall. So where is orbital floor? So here you have the orbital floor, isn't it? So here you have the orbital floor. So here looks like that is the zygomatic bone, and here you have the maxilla, and these two seem to be forming the floor. And the medial wall, what and all you have? Medial wall, you have a lot of structures. You have ethmoid bone, lacrimal bone. Is the palatine bone part of it? Anyway, so what is getting affected? The floor, and usually the floor and the medial wall get affected in a blowout fracture. Etiology, they are saying it is a result of trauma to the orbit by a relatively large, often rounded object. It has to be large object, a round object such as a tennis ball, cricket ball, or a human fist also. If you make it a fist also, if you make it, it will be the size of a ball, or it will definitely be larger than the size of the orbit, right? Or part of an automobile. All these will be large. They have to be large, and they have to be, they can be round, right? The force of blow causes backward displacement of the eyeball. So what is going to happen to the eyeball? See, this is the orbit. Here you have the eyeball. Somebody is punching from front. There's a backward displacement of this eyeball. Increase in the intraorbital pressure because of this displacement looks like. And the resultant fracture at the weakest point of the orbital wall. So this eyeball is coming back. Oh, that's why they are saying it is indirect kind of okay, so it is coming back. There is increased pressure. At the weakest point, this orbit will give way. They are saying the weakest point, see, what gives way is the orbital floor. First, orbital floor gives way, and then the medial wall gives way, okay? Usually this, what are they saying here? Usually this point is the orbital floor, but this may be the medial wall, okay? So it can be either floor or wall. So did you understand why it is indirect now? Let's move on. So there are classifications. As usual, everything will have more types under them. So under this also there are two types: pure blowout fractures and impure blowout fractures. Pure means they are not associated with the involvement of orbital rim. Impure means these are associated with other fractures about middle third of the facial skeleton. Middle third of facial skeleton means what? If you make it 3, this will be the middle third. So if this part is involved, that will become impure blowout fracture. But what is pure blowout fracture? These are not associated, we are saying. These are not associated with involvement of orbital rim. So that means it did not go beyond this, or what? Anyways, there is pure and impure. Impure means there is the middle third of facial skeleton is also affected. So guys, the rim is what you see here. Just look at this. The frontal bone, the zygomatic bone, and the maxilla together, they form the orbital rim. This, if it is not affected, but still the floor is affected. Okay, the floor is definitely affected. That becomes a pure orbital blowout fracture. This is pure. But along with this floor, if everything else, middle third of face, everything, it is impure blowout fracture. So there are two. Okay, in blowout fractures you have two. What are the two? Impure and impure. Pure and impure. So we're done with the classification, guys. So orbital rim is safe. That means it is pure. So only floor is affected or something like that, right? Impure means middle third of facial skeleton is also affected. Okay. Clinical features, what will happen to a person who has been punched like this? Periorbital edema and blood extravasation. So periorbital, around the orbit there is edema, blood extravasation in and around the orbit, such as conjunctival ecchymosis occurs immediately. Conjunctival ecchymosis is what? Subconjunctival hemorrhage or something. It occurs immediately. This may mask certain signs and symptoms seen later. So conjunctival ecchymosis hemorrhage. So what are they saying here? Periorbital edema, blood extravasation in and around the orbit, subconjunctival ecchymosis. Okay, then all this we'll have to write. Then emphysema of the eyelids occurs more frequently with medial wall than floor fracture. So if medial wall is fractured, the emphysema of the eyelids occur more often with that. So if this is the orbit and medial wall is fractured, then emphysema of the eyelids will occur. Emphysema is what? Like air-filled something. So this is kind of weird, right? Emphysema of eyelid. Where will the air go into the eyelid? Paraesthesia and anesthesia in the distribution of infraorbital nerve. This is important. What is affected is the infraorbital nerve. Okay. So lower eyelid looks like the cheek, the side of the nose, upper lip, upper teeth. So they will not feel sensation. Where and all? Lower lid, the cheek, the side of the nose, upper lip, then upper teeth also. No sensation or less sensation. Look at this here. You have the trigeminal cranial nerve 5. From that, you seem to be getting the maxillary nerve. From that, you seem to be getting the infraorbital groove and canal, infraorbital foramen. So, infraorbital nerve is it? So, and what does this nerve supply? So, looks like it supplies exactly what they said just now. Lower eyelid, cheek, some part of the nose, upper lip and upper teeth. Exactly that seems to be covered in this photo. So, infraorbital nerve, paresthesia, anesthesia, lower lid, cheek, side of nose, upper lip, upper teeth. Okay, then ipsilateral epistaxis as a result of bleeding from maxillary sinus into the nose. Okay, so he has epistaxis here, and strangely this is not from Little's area or something. It is from the maxillary sinus, bleeding from maxillary sinus. So it is ipsilateral epistaxis, same side epistaxis as a result of bleeding from where? From the maxillary sinus. Okay, so that's important. Now let us move on. Blowout fractures, still we are continuing with clinical features only. Proptosis of variable degree may also be present. Then enophthalmos also can be present. But how can both of these be present at the same time, right? Okay, initially it is proptosis. It looks like it's popped out. Because of the edema and hemorrhage, initially proptosis, okay, it is seemingly popping out. Enophthalmos means it looks inset, right? So now how enophthalmos? Mechanical ptosis. So after about 10 days, as the edema decreases, the eyeball sinks backwards. Okay, so initially proptosis, then the eyeball sinks backwards and there is enophthalmos, that is it's inset kind of an eye, right? And somewhat it goes inferiorly. The enophthalmos, it is somewhat not inside, it's inferior, downwards, okay? And there is mechanical ptosis of the eyelid. Ptosis means drooping of the, abnormal drooping of the upper eyelid. So that is what you can see here. So you can see this eye seems to be inside and lower, right? Inside and lower, and the upper eyelids drooping. So ptosis. And all this they are saying after 10 days looks like. Okay. 3 factors responsible for producing enophthalmos are, so there are 3 factors which cause this enophthalmos. Orbital fat is escaping into maxillary sinus. That means because of through the floor or something, the fat has gone into the maxillary sinus, at least on this side, right? So that is one of the reasons. The fat has gone into the maxillary sinus. Backward traction of the globe went backwards because of the trapped inferior rectus muscle. There's backward traction on the globe because of this inferior rectus muscle being entrapped. The globe has gone backward. So if this is the orbit, this is the globe, there is inferior rectus. Because of this inferior rectus getting entrapped or something, there is backward traction on the globe. Enlargement of orbital cavity from displacement of fragments. So what happened? Here you have the orbital cavity. This is the eyeball, right? So what happened? The displacement of the fragments, so many fragments of bones, right? Enlargement. So this cavity got enlarged and this eyeball got pushed. Looks like it got pushed inferiorly. So inferior, you can remember. Where is that word? Inferiorly. Somewhat inferiorly, they are saying. Okay. Now let us move on, guys. Some more clinical features are there. Diplopia. So after the edema decreases, they will realize that there is diplopia. It typically occurs in both up and down gaze. Both up gaze and down gaze, they'll have diplopia. Double diplopia they have. Why? Because entrapment of the soft tissue structures in the area of the blowout fracture, there is entrapment of these tissue structures. The presence of muscle restriction. Obviously, muscle restriction is happening. That is why they're having diplopia. They cannot move the eyes. So the visual axis of both the eyes won't be parallel, something like that you can say, isn't it? So that will cause diplopia. You can confirm this by forced duction test. What is forced duction test? They will hold the eyeball. They will give anesthesia first of all. If this is the eyeball, this is your cornea. They will hold it with forceps and they will try to move it. If it moves, that means to say the muscles are fine, right? And the nerve supplying the muscles are damaged. It will be paralysis. But if you cannot move at all, even with force, the eyeball, it means to say that there is some restriction. What is it called as? Yes, that is restrictive because of some scar or fibrosis or some problem with the muscle, right? So the muscles are very rigid, restrictive. So forced duction test will be positive in that case. Positive means you cannot move actually. So they will do a forced duction test. You will try to forcefully move the eyeball. If you cannot move, that means to say it's positive. That means to say the muscles, some problem with the muscles, scarring, fibrosis, some problem with the muscle. Okay. So because of these things, there will be what? Diplopia. Severe ocular damage associated with blowout fracture is rare. So there can be severe ocular damage, which is though rare it is. This is because blowout fracture is a nature's way of protecting the globe from injury. So this is nice, right? Blowout fracture is a way of protecting the globe. So the globe gets inset and ophthalmos, inferior, etc. But the globe is protected. You're protecting the eyeball, right? Nevertheless, the eye should be carefully examined to exclude the possibility of intraocular damage. So yes, the orbit is getting damaged so that it can protect the eye, but you should always check the eyeball also to ensure that there is no damage to the intraocular structures. So guys, clinical features over. Now we have to order some investigations, X-ray, CT scan, etc. Then after investigations, we will look at treatment. Okay, that's it. Just 2 more things left. So imaging, orbital imaging, remember you can do X-ray, CT scan, MRI, right? Standard things you will write. Now in X-ray, they are saying you will order Waters view something. And there you will see this hanging drop sign. What is this hanging drop sign? Let's.
Hanging drop.
Yeah, you see a hanging drop sign. What sign?
Hanging drop sign.
Yeah, and in CT you will see teardrop sign. Teardrop. So guys, this is Waters view. And in this you can see a hanging drop sign. Opacity of the superior maxillary antrum from orbital contents herniating through the floor. So the orbital contents have herniated through the floor. So here they're talking about computerized tomography and MRI, great value they are saying. So what will you see in the coronal sections? Herniation of contents into maxillary antrum, that is called as hanging drop or teardrop sign. Okay. So what do you think? Is this the orbit, by the way? Is this the orbit? Okay. So imaging done. What next? Treatment. Let's look at the treatment. Management. General measures what people should do. They should avoid blowing nose. Okay. As the nose blowing may contribute to surgical emphysema and herniation of soft tissue. So don't blow nose. That one. Then systemic antibiotics, analgesics, anti-inflammatory drugs to avoid infection, to decrease pain, to reduce swelling. Cold compress immediately following trauma. It may decrease swelling by causing vasoconstriction. So all these are management. Let's move on to last slide here. Surgical management. Surgical management, you can repair the orbital floor with or without implants. You can repair the orbital floor. Many cases you don't need to do anything, they are saying. But if surgery is indicated after 10 to 14 days of injury, looks like they want all the edema to subside, etc. Right? Indication for surgical intervention include diplopia. So surgical intervention, when will you do? Diplopia which is not resolving significantly, right, in early days after trauma. Fracture with large herniation of tissues into antrum, so you'll have to surgically bring them back, looks like. Incarceration of tissues in the fracture resulting in globe retraction, increased applanation, tension or attempted upward gaze. What is incarceration? Imprisoned. So these tissues are imprisoned in the fracture. So looks like you will have to repair it surgically. In ophthalmos greater than 3 millimeter. So if the eye went in by more than 3 millimeter. Okay. Any of these factors alone or combined indicate orbital repair. So these are the indications for surgery in blowout fracture. Now let's take a quick recap. Blowout fractures of orbit. What is fractured here? The orbit is fractured. How? Because of blowout. Okay, somebody punched this person. Now blowout fractures are isolated comminuted fractures. The orbital walls are pressed indirectly. Okay, that means the eyeball goes in, kind of a thing, and indirectly the pressure will create this fracture. Okay, what is affected most? You can say orbital floor, medial wall. So here what happens, object which is round and larger than the orbit, relatively large object which is hitting the eye, it will displace the eyeball backward. It will increase the intraorbital pressure. Because of this pressure there is fracture and the weakest point will give away. That could be either be the orbital wall, orbital floor or medial wall. Classification, you have two types, pure and impure. Pure means the rim is not affected, rim is perfectly fine, orbital rim is perfectly fine, but floor and all can get fractured. Impure means it is associated with the fractures of the middle third of the facial skeleton. Okay, coming to clinical features, you will see periorbital edema, blood extravasation, subconjunctival ecchymosis, emphysema of eyelids, paresthesia, anesthesia. Remember, inferior orbital nerve is wherever that distribution is there, it will get affected. Ipsilateral epistaxis, same side nosebleed, right? And they are saying the bleeding comes from where? Maxillary sinus, because the orbit's content went to maxillary sinus, and from the maxillary sinus, epistaxis on same side. Then continuing with clinical features, these people can have initially proptosis because of all the edema, then they'll have inophthalmos, mostly inferiorly they can have, then mechanical ptosis. Okay, inferior rectus muscle will be affected, it will be trapped. Diplopia can be there, double diplopia. Forced duction test will tell you whether the muscle has got restricted or not. Severe ocular damage. So this is the forced duction test. They will try to move the eyeball, and then if it doesn't move, that means to say muscle restriction is there. Severe ocular damage is usually not associated because blowout fracture is a way of keeping the eyeball safe. Imaging, X-ray, CT scan, MRI, you will see hanging drop, teardrop sign. What is that? The herniation of the orbital contents into the maxillary antrum. What you should do, you should not blow your nose, you should take antibiotics, anti-inflammatory analgesics, then you should do cold compress. Surgical management can be done with or without implants. After 10 to 14 days, if there is more diplopia, if there is a large herniation is there, or incarceration of tissues, that means there's imprisonment of these tissues in the fracture, which is resulting in globe retraction, increased applanation tension on attempted upward gaze, in ophthalmos greater than 3 millimeter. All these will be indications for surgery in a blowout fracture. Otherwise, they say you don't need to surgically intervene. So here we are done with blowout fractures of orbit. Hope you learned something. Bye bye.